We're going to go ahead and get started. I wanted to welcome everyone to tonight's webinar. I am your host and moderator, Lauren Levine. As of this morning, we have a huge turnout. Oh my God, we had 1,300 people that are registered for the webinar. A good chunk of you are already here. I'm only going to speak for a couple of minutes or so. I want to make sure that Dr. Nazarian can speak for as long as he needs. Many of you have been on these webinars in the past. For those of you who maybe this is the first time or it's been a while, you have a control panel on your screen. You can go ahead and type in your questions as you think about them. The basic format is that Dr. Nazarian is going to speak for a bit. Our sponsor is going to speak for a few minutes. We'll open it up to Q&A. I'm going to apologize ahead of time. There's no way we're going to get to all the questions because we usually get close to 100 questions, and we usually only have about 15 or 20 minutes to get to them. But I'm the only one that can see the questions. I'm going to try to find the ones that I think are really the most relevant, and we'll do our best to get to as many of them as we possibly can. So just type in your questions as you think about them, and we'll try to get to them as soon as we're done. In the next few days, you will receive a few things. This webinar, like all webinars, is being recorded. So don't worry if you can't stay until the end, or you get distracted, or want to go watch the State of the Union. I can't imagine why when this is so much more interesting. You're not going to miss anything. Don't worry about that. During the webinar, Dr. Nazarian is going to be demonstrating a number of products that he uses, such as Forceps and bone grafts, a number of these which are exclusive to GoldenDent. I wanted to thank GoldenDent for their ongoing sponsorship of this webinar. We've done a series of webinars with them in the past. We've been doing this for a number of years. If you're in dentistry, you know who GoldenDent is. They have this great ongoing commitment to dental education. After Dr. Nazarian is done speaking, Kurt Lawler from GoldenDent will come on at the end of the webinar. He's going to offer some fantastic special pricing and some educational opportunities. As part of that, if you have attended live, we don't do this for people who are watching the recording, you will receive a continuing education certificate. GoldenDent handles those. Please give them time. When we have 1,300 people on the webinar, these all get mailed out in snail mail. They're not sent through email. It takes oftentimes a few weeks. So without further ado, I wanted to welcome our very distinguished guest and speaker, Dr. Ara Nazarian. He maintains a private practice in Troy, Michigan, which apparently is a great place to be because every time a drop of rain comes, they cancel school, with an emphasis on comprehensive and restorative care. He's a diplomat of the International Congress of Oral Implantologists. His articles have appeared and been published in many of today's popular dental publications. He's consistently listed as a top dental educator. He's conducted many lectures and hands-on workshops and webinars with us on aesthetic materials and dental implants throughout the U.S., Europe, and Asia. He's on the faculty for Amplified Dental Training, which teaches atraumatic extractions, grafting, and immediate dentures. And he also founded the Ascend Dental Academy, which teaches all aspects of dental implants. So without further ado, Ara, thrilled to have you back here, and we're looking forward to tonight's presentation.
Great. Thank you, Dr. Levine, and welcome, everyone. Good evening. This evening's webinar is talking about full mouth extractions, leveling, and grafting in one appointment. Well, although my practice is in the suburbs of Michigan, we still see these types of patients presenting to our practice. And a lot of times we'll see advanced periodontal disease, we'll see gross decay, whether it's due to soda, drug use, neglect. We also see the effects of severe bruxism and parafunction. And in a lot of these cases, full mouth extraction is required. Well, if full mouth extraction is required, what is your recommended treatment afterwards? Well, when we look at the available options to propose to our patients, we start from A and go to Z. In other words, we start from the simplest and most economical to the most complex and most expensive. So if we take a look at the first option for our patients that need full mouth extraction, well, then we can propose to them complete dentures. Second in line that we can propose to our patients is some type of an overdenture, and the first one we would start with is small diameter implants. The second that we would propose is some type of overdenture that is on traditional implants. Usually in the lower arch, the minimum number of traditional implants we use is 2. And in the upper arch, usually the minimum number of implants that we use for an overdenture is 4. Next, we have an overdenture opposing a fixed bridge, or we have fixed bridges opposing each other, and usually we're avoiding the sinus cavity by angling the most distal upper implants, whether it's all on 4 or all on 6. And then lastly, we have the Cadillac treatment, which is axially placed implants, or what we call parallel placed implants, where their patients usually getting second molar to second molar in the upper and lower arches. And in these cases, even sinus lifts may be performed. Here's a typical example of a denture makeover. This patient presented to my practice with severe periodontal disease as well as advanced decay in a lot of her teeth, especially at the cervical portion of those teeth. And so in one visit, we extracted, leveled the bone, grafted, delivered the immediate dentures, and then several months later, relined them with a hard reline. If in fact the immediate dentures don't come out the most ideal or the way that we'd like, then in 3 months we would actually make a new set of dentures. But quickly you can see in her eyes, it really tells the whole story. What I tell my patients when I show them before and after photos is that the eyes don't lie. The eyes really tell the whole story. And so we came up with immediate dentures that look very natural. However, you'll see in the presentation sometimes patients want Hollywood white. So that is also an option when we look at removable dentistry as well. So let's take a look at a clinical case. In this clinical case, we'll be talking about extractions, leveling, and grafting, followed immediately with dentures, then followed by relining those dentures to the final fabrication of the definitive dentures. So when a patient comes into my practice, the first thing I'll do is listen to what their chief complaint is. And in this patient's case, she presented telling me that she just hated her smile. She had several teeth that were broken down at the gum line with a lot of decay, and she knew that she needs to have these teeth extracted. However, she was very apprehensive because of very bad past experiences that she encountered. So she wanted to be able to do this under IV sedation, but in the end, she wanted straight white teeth, which she never really had, even as a child. So when patients present to my practice, and before I start having them fill out all the paperwork, the first thing we'll do is give them a tour of the office. This is a tour that's only going to be a few minutes, so we're not spending 20 minutes showing them the whole office. But in contrast to what most patients experience, which is, hey, fill this paper out and then give me your insurance card and let's take a look at what your needs are. This approach is very different. It makes them feel special, but it also takes the fear away from coming into the office. Also, we'll show them a lot of the high-tech equipment that we have, whether it's the intraoral scanners, whether it's our sterilization center, whether it's our CBCT, so on and so forth. So a typical example would be a patient presents, they're greeted by the front desk coordinators, and before we have them sit down, we'll say, we're just going to give you a quick tour of the office and get you familiar with what Dr. Nazarian does for his patients. So they'll take them through the hallway, and we call it the Hall of Fame. In that area, there's several articles that are posted on the wall that are framed. And so what the staff is really doing is they're building my credentials to the patient. And so even before I've met the patient, they know about me. They've heard that I lecture not only nationally but internationally. And so the staff really builds me up. Once they've gone through this hallway, they'll be shown the photo room. And the photo room is an area where there's several large photos of before and after pictures of my actual patients. And you know, in the past, a lot of us would purchase these before and after patients, but they're really, I think, the most effective way of portraying that you do this type of work is to really show the photos that you actually do for your patients. And this really sells dentistry. It really educates them, and they see that you have a passion for being able to restore people's smiles and restore their life. Once we've given them this short tour, we'll also take them in the back where we show them the sterilization area. You know, one concern of patient that's very important is, hey, are these things being sterilized? Does the office have a nice smell to it? Or do I smell burning teeth? Are these instruments clean? So these are things that we sometimes overlook as dental providers, but it's very important for these patients when they come in. Once we've given them this tour, we'll return them to the lobby and have them fill out any paperwork and questionnaires. And while that's being processed and put into the computers, my staff will give them a before and after book to look through actual patients that have gone through similar types of treatment. So our goal is really to educate them step by step. So once they come into the clinical area and we've already collected the health questionnaire and everything, then it's the assistant's job to acquire x-rays. Whether it's a full mouth set of x-rays or a Panorex, we definitely want to collect all this data. We'll also do clinical findings as far as examination. But one thing that I want you to do separate that is different than what you've been doing in the past is to acquire photos. And not only do we acquire extraoral photos like a face shot and a smile shot, but we'll also acquire intraoral photos. The camera that I have actually will Bluetooth this to the monitor in the room, so we'll see a set of 4 photos already on the monitor before I've entered the room, and the assistants acquire this. The other thing that I like to do is have maxillary and mandibular models achieved as well. And if you're not taking impressions and you're already digital, then you can do this digitally, or you can use alginate, or we'll talk about a material called Silginate, which is really nice. Once we've acquired all that information, if we're going to be doing implants, we'll also get a CT scan of these patients. So this is the traditional set of 4 photos that is essential when doing case presentation. The first one in the top left is the smile view. The second one below that is the retracted view with an open bite. And we show this with an open bite so we can see the incisal edges of both the top and bottom teeth. On the right side, we'll acquire a occlusal view of not only the maxillary arch, but the mandibular arch. So when a patient comes into the operatory for their clinical examination, the first thing the assistants will do is capture these 4 photographs that will be Bluetooth immediately onto the screen in the operatory, and then they'll acquire the necessary radiographs. When I come into for the clinical examination, my goal is to not only identify the caries and areas of bleeding gums and probing depths, but also any crazed lines and cracks, any failing restorations, areas of wear or mobility of teeth. And if we're thinking about doing implants, we can see the areas highlighted in the yellow that are also available, which are those areas that have remaining bone, edentulous areas, areas of attached gingiva, and if they are wearing a partial or a denture, if they have those prosthetics with them. So if we take a look at this retracted view, we can quickly identify that this patient has severe decay. We also see some of the wear on these teeth. We don't know were there crowns existing on these teeth that decayed off or not. We also notice in the lower arch she's got a fixed bridge, but you can see there's quite a bit of plaque acquired around the cervical of these teeth, and she may be avoiding these areas because they're uncomfortable. So these are areas that we need to identify. We also see some crazed lines in the teeth, illustrating there may be some fractures. When we look at the occlusal aspect of these teeth, we quickly recognize that trying to do root canal cores and crowns in all these teeth may not be the best long-term treatment plan for this patient. The best treatment plan may be to, number 1, remove the areas of decay and infection by extracting these teeth and grafting the area. and building the foundation for future implants. In the lower arch, we also notice that there's some teeth that have had some dental work on them with root canal core and previous crown restorations. And we saw with recurrent decay that a lot of these restorations were lost. One of the things we'll do is acquire a Panorex and also a CBCT. This is the Carestream 8100. This is a great unit that we use in our practice, and it has a very small footprint, and it allows you to quickly achieve not only 2D but 3D images. And you can range the field of view anywhere from 4x4 all the way to 8x9, which is more than enough for the type of implant dentistry that I do. So if we take a look at this Panorex, we can clearly see the areas of decay. We also see the areas where there is severe infection. For example, if you take a look at the number 19 area, you can see the large radiolucency around those teeth. So although partial dentures may be an option, long-term and knowing the dryness in her mouth, she'd be back for some issues. So we want to highly consider possibly extracting all these teeth. Well, we illustrated to you the different types of dentistry that I offer to my patients, and these are some of the price ranges of what these types of treatment are. So if we look at an upper and lower denture, we're looking at about $2,000 plus the cost of the extractions. If we're looking at an upper denture and a lower overdenture with maybe small diameter implants, we're looking at about $7,500 in addition to the price of the extractions. If we go with traditional overdentures on traditional size implants, we're looking at about $9,000 or $10,000. And then, as we can see, anything fixed in my practice is about $25,000. So in the upper right corner, if you look at an overdenture, that's about 10, and a lower fixed bridge that's about 25. That quickly adds up to 35,000. One of the things that I found in my practice is, instead of trying to add everything up very time-consuming procedure, I rather just bundle things and have an idea of the price range. So the first thing I would do to this patient is say, Mrs. Smith, would you like teeth that are fixed in your mouth, or would you like teeth that snap in and out of your mouth? And everybody always will start with, I want fixed teeth. Okay, well, if you want fixed upper and lower teeth, you're looking at a minimum of about $50,000, and let's say a few grand or a couple grand for the extractions. The first response of the patient may be, that's definitely not in my budget. There's no way I can afford $50,000, even if I try to get assistance with, let's say, Care Credit or Lending Club. My credit's not that great, so there's no way I can do it. Okay, well, we found that most patients complain of a lower denture or lower overdenture, so we can go with a fixed option on the bottom, which is 25, and possibly an overdenture on the top, which is 10. So we're looking at about $35,000. No, that's really not in my range. Really, I probably can only afford maybe $5,000 or $6,000. Well, in that case, all we can really do is extract the teeth and provide an upper and lower denture. We'll build the foundation for implants, and this way later in a year or two, if you decide to get implants, then we can upgrade you to one of these other treatments. So in this particular case, this patient decided to go with upper and lower dentures after her extractions. So one of the things I found dental providers do is they don't talk about the cost early on in the consultation appointment. They're scared to talk about it. Where in our practice, we actually like to talk about it and see what fits their budget, and then go from there and come up with a treatment option that will fit that way. And they can always upgrade to implant therapy, whether it's overdentures or fixed later on. So this is one important pearl I think you should take to your practice when presenting these types of things. This is much more effective than you telling a treatment coordinator to put all the different extractions within the computer. By the time your treatment coordinator does that, the patient has already lost interest, or they've already been in your office for 45 minutes and now they have to rush to get to work. So bundle your costs or have an idea of what these bundled costs would be, and then you can easily add the extractions to it without doing complicated math. Once we've presented this to the patient, we'll give her some information and some articles, some testimonials from actual patients, and let the patient go home and think about it. Well, once the patient has decided that she is in fact going to go through with this treatment, we'll have what we call a records appointment. At the records appointment, we'll get the payment in full for what we're going to be providing for the patients, and then this way we'll be documenting different things to inform the laboratory, such as the incisal edge and the midline. So once she's decided on the treatment and she returns, our goal is to collect payment because we're going to have a lab bill at this time, and then forward any photos, impressions, bite registration, so that we lock in the date for the IV sedation. So the first thing we're going to do is, on this photo that we've acquired, is mark where the midline is. The last thing you want is to have a new set of teeth, whether they're removable or fixed, where the midline is off. So here we can see we're going to draw an imaginary line through the center of the nose to the middle of the chin, and we can see already that her midline with her existing teeth is off, so we don't want to replicate that in the denture. The other thing that we like to tell our laboratory is that we like the principle of golden proportion. So we know that the centrals are going to be about 1.6 larger than the laterals, and the laterals are 1 compared to 0.6 in relation to the canines. The other thing that I like to inform the laboratory is to have a little axial tilt towards the mesial of the dentures, and this gives the appearance of them to be more realistic, not only to the patient, but to other people that may look at these patients. We don't want to have them straight in a line looking like soldiers. Here we can see the bite. Whenever you capture a bite, I recommend using retractors and have the patient practice in biting in central occlusion. And when you use retractors and you place bite registration on, you don't have the cheeks moving the bite registration off the occlusal surfaces of the teeth. So using retractors when achieving or acquiring the bite is very essential in achieving an accurate bite. So here you can see we've acquired the bite using the retractors and having the bite or the patient practice the bite first, and then using our futar from Kettenbach, we've acquired that bite. In that bite, we can also mark with a Sharpie, or if you want, before it sets, with a stick, again, where the midline should be. So this is the bite registration material. This is from Kettenbach. It's called Futar Bite Fast, and it works very, very well. So if you take a look, you see that we've not only acquired the bite, but we've used an alginate alternative to capture the upper and lower arches. This is also a material from Kettenbach called Silginat. It's a replacement for alginate because it can be poured up multiple times. It's a polyvinyl siloxane, very much like impression material, but it's an inexpensive polyvinyl siloxane where the assistants don't have to worry about pouring it up immediately. So you can see the models that are poured up from the lab to fabricate the immediate dentures, and we've captured the vestibular areas very nicely using the Silginat impression material. From this, the laboratory will start grinding the teeth out and make a working model for the immediate dentures. Now, this is taken from one of my mentors' books, Dr. Carl Misch, and when we're looking at dentures, in the upper arch, we want there to be contact on the lingual cusp, and in the lower denture, we want that contact to be right in the central grooves. And this stabilizes the denture, especially if you're not having implants placed. We want the occlusion to be stable and not causing these dentures to tip. So we want the axial load to go right on top of the ridges, so that the force is going on the long axis here. So usually in the upper arch, we'll go with a more lingualized occlusion and anatomical tooth, and in the lower arch, we'll use a non-anatomical tooth form. The teeth that I prefer to use, whether they're the immediate dentures or the final dentures, are the Panorex 2 from Ivoclar Vivadent. These are very aesthetic and lifelike teeth. Not only do they look lifelike, but they don't wear very quickly. So whether you're doing dentures, overdentures, partials, or implant retained overdentures or hybrids, these teeth don't wear out and they don't stain very well. So if you look, the incisal edge, we're using PMMA type of material on the lingual aspect, and then on the facial aspect, it's a nanohybrid composite. So it gives it a very lifelike translucence, so to speak, of the teeth. And so you don't have this monochromatic looking tooth. So here the laboratory has fabricated from our impressions and bite the immediate dentures using the Panorex teeth. And my nurse anesthetist has put our patient to sleep. And here you can see I'm anesthetizing the patient. This is a surgical headlight I really like. It's Innova headlight from the company Innova from the Midwest that works very well. And so here you can see how many teeth we're going to be extracting. So there's a combination of 23 teeth that we need to extract in one visit. We're going to curette these areas out, remove any granulation tissue, rinse that with sterile saline, level the bone, and then place grafting material into these sockets. Well, when extracting teeth, our goal is to have an ideal tooth extraction. And so when we look at the definition of an ideal tooth extraction, we see it as the painless removal of the whole tooth or root with minimal trauma to the investing tissues so that the wound heals without compromise and no postoperative prosthetic problem is created. Let's face it, we all can take a tooth out, but our goal is to take a tooth out atraumatically without damaging the surrounding tissues or bone. And so that's always my goal, and this is what I always remember when I'm removing a tooth. Well, when removing teeth and trying to keep this atraumatic, my goal is to use the physics forceps. I've been using the physics forceps now for over 10 years, actually over 11 years. And what I found is it works like a modified class 1 lever. In other words, you're leveraging the tooth out the path of least resistance and you're loosening it. Once you loosen it, then you can use a tooth delivery forceps or a regular forceps to remove it. But you're finding 90% of the work is being achieved by using this modified class 1 lever. Well, if you really think about it, what makes more sense? Trying to remove a bottle cap with like a plier or a forceps, or using some type of leverage to remove the bottle cap? And so the physics forceps works in the same manner. When we look at a nail, again, we're looking at the basic principles of physics. And if we try to use something that's not a lever, we can get that nail out, but we're going to be really working hard to get that nail out. So we rather go with some type of leverage or modified lever. Well, in fact, Archimedes is quoted as saying, "Give me a place to stand and a lever long enough and I will move the world." We saw this also with the Egyptians. So when we look at it in regard to teeth, our goal is to take the physics forceps and place the beak on solid tooth structure. If for some reason you can't get the beak on solid tooth structure because the decay is far extended below the gum, then you need to create a purchase point. In that case, we'll use like a 169 or a 170L surgical burr to trough just a little bit between the bone and the tooth so that you can get that beak onto solid tooth structure. So in the illustration, you can see that the beak is apical to where the decay is so that we can in fact get onto solid tooth structure. The second step in utilizing the physics forceps is to take the bumper and place it as high up into the vestibule as possible. Now, depending on the depth of this vestibular area, you'll find that the greater the distance from the beak, the better the leverage. So if for some reason you can't get the bumper up as high up apically, you'll find that it may not be the best lever, so it may just take a little longer to take that tooth out as compared to if the bumper is placed a little higher up into the vestibular area. So number one, we've placed the beak on a solid tooth structure. Secondly, we've taken the bumper and positioned that as high up into the vestibular area. The greater the distance from the beak, the better the lever. Now at this point, without squeezing the handles or moving your arm, just using a wrist action, our goal is to pivot or rotate this tooth out the path of least resistance. So at this point, we'll put just a little bit of pressure to be able to leverage this tooth out. What happens is the pressure starts to build up and the enzyme hyaluronidase is released. And by using unrelenting force, in other words, we're not going back and forth, we're just going to keep a steady, constant pressure in this rotational movement until all of a sudden we feel the tooth give or there actually be a little bit of pop in the tooth. Once the tooth has loosened up, we're going to stop the rotation, remove the forceps from the tooth, and either use a regular forceps, you can use gauze, or you can use a tooth delivery system to remove the tooth from the socket. So here, we're not just saying this. This is actually a reference from Frazier in 1997 that hyaluronidase enzyme is released when you have unrelenting trauma to the periodontal ligament by putting constant steady force. So this is the great aspect when we look at biochemistry and tooth extractions. Well, once the tooth is removed, we want to curette that area out of any granulation tissue. So this is the soft tissue and grafting kit from GoldenDent. I have about 5 or 6 of these within my practice because I don't want my assistants running around for separate instruments. If I'm doing extractions and grafting, then we want these instruments as a pack and ready to go. So these are always also out when I'm doing extractions so that I may be able to curette or smooth the bone down or pack or suture. Everything is there that is required to do soft tissue manipulation as well as grafting. So the first instrument from this pack that we're going to utilize is the curette. We're going to go ahead and sever the PDL with either the curette or a mucoperiosteal elevator. So let's see exactly how we're utilizing these instruments in this particular case. So before I even put forceps on here, we're going to go ahead and sever any tissue around here using the curette or the mucoperiosteal elevator. So I'll just go there and make sure that we can get the beak of the forceps on the solid tooth structure. So if I see that there's decay there, then we'll go ahead and just reflect a little bit of a flap or just sever that area of the gingival tissue so we can get a solid purchase point. Now, before putting the forceps on, a lot of people had trouble just imagining not using any type of elevation or luxation. So we came up with this instrument called the Wedge. And the Wedge essentially is the perfect pre-step in your atraumatic extraction process. How it works essentially is having a strong handle that's like an elevator, but having a tip that's very sharp, almost like a periotome, but strong enough so that it's not going to bend or break. So what we're doing is the wedge should be used slowly by going down the long axis of the tooth, and you're going about 3 to 4 millimeters into that space between the bone and the tooth. And then you'll just make a slow wedging motion or small rotation. And what we find is this helps as a pre-step in loosening the tooth before you use the physics forceps. It definitely shortens the period of time to be able to take a tooth out. So this is our sort of pre-step instrument that we use, and that's called the wedge. Once we've done that for about 20 or 30 seconds, we'll go ahead and use one of the physics forceps. These are the standard series, and in the standard series you have an upper right, upper left, upper anterior, and then you have a lower universal. So we're starting with the upper right section. And so here you can see how we've adapted the beak on the solid tooth structure. The bumper is taken as high up as possible into the vestibular area. So you can see this is a very shallow vestibular area. and using a rotating or pivoting rotation or movement, we're going to remove this tooth. And so we continue this all the way around. We also do the anteriors as well with the upper anterior forceps. And here quickly we can see within a couple minutes we've extracted several teeth. Now remember, these teeth were not jeopardized periodontally so much as they were due to severe decay. So these forceps work very efficiently and very effectively. Here we can see that we've extracted all the teeth. When I do immediate dentures, I don't like to just leave the sharp tines of bone. So I will actually reflect a larger flap and then take either a bone file or a bone burr and level everything. But before I do that, I want to either A, curette the sockets out and remove any granulation tissue, or B, use a burr for those stubborn areas. So this is a burr kit that I developed that GoldenDent distributes. And so the first 3 burrs are called tissue or degranulation burrs. The second burr is a carbide burr used for sectioning teeth or decorticating bone. And then the last 2 burrs are what we call tree burrs or bone leveling burrs. These go into the straight nose cone of your surgical handpiece, and they're used to level larger amounts of bone. So here you can see the degranulation burr, and I'm going into the socket and removing with my surgical handpiece any stubborn granulation tissue that I was unable to remove with the curette. And here you can see that. Once we removed all the areas of degranulation tissue, we're going to smooth down the sharp tines of bone. And so this is the bone file within the GoldenDent kit, grafting kit that you can use, or you can use a burr. Before we start placing any grafting, we'll go ahead and check the immediate denture and see if in fact it's seated all the way. The last thing you want to do is suture after you've grafted and then try the immediate denture in, and you find that it's not seating passively. And so most dentists will then relieve the denture and then it becomes paper thin. What I recommend is before you graft, before you suture, check the immediate denture to make sure it seats passively. If it does, great, then you can graft and suture. If it doesn't, then smooth down the bone and you don't have to worry about opening it up after suturing if you've done it before. So our goal is to graft, and we know that's setting the foundation for implants. So obviously this is our goal, and I always tell patients, look, I know you may not be ready for implants now, but it's much easier to preserve than to try and create later. So our goal is to graft at the time of extraction. And now if you do want to go with implants in the future, we can easily use a surgical guide that's tissue borne with a tissue punch and not have to reflect this flap looking for bone. If we don't graft, then we don't always get predictable results. That area may or may not fill in, and if it doesn't fill in, now you just may not have ideal bone for implant placement in the future. Another way that I illustrate the importance of grafting to the patient is using this model called DemoDent. This is a model that I created. This also is distributed by GoldenDent. And if you look, not only can you illustrate a socket, you can illustrate occlusal or interproximal decay, a failing amalgam restoration or a crack, or a core and crown restoration. So I'll show them the first model that shows socket grafting, and I'll let them know, look, if we don't fill the hole here, then these thin walls of bone will collapse and cave in, and later if you want to get an implant, we just may not have a sufficient amount of bone remaining to place an implant. This is taken from a clinician's report. This was a great study, May 2010. Dr. Gordon Christensen had several reasons why socket grafting is important. And if you look at number 5, I think number 5 is really the most important. It's always easier to preserve bone with socket preservation as trying to create later, which is going to be much more complicated. Well, let's take a quick look at the different types of grafting material. The first type of grafting material that's available is a xenograft. A xenograft means it's from a different animal. In other words, it's not human. So usually we see bovine bone, which is cow bone. We have seen cases where they use horse bone, but usually the most common one that's out there is bioos. Allograft is human donor bone. It comes in various forms, which is as a powder or a gel or as a putty. And so you can see there's a variety of different types of allografts. Alloplast is a synthetic bone. One of the most common ones is osteogen. It's using the osteogen material, which is suspended in a bovine Achilles tendon. And then we have autogenous bone, which is the patient's own bone. And sometimes we have another type of autogenous bone, which is taken from their teeth, and that's called the smart dentin grinder. The smart dentin grinder, what we do is we utilize the patient's teeth by removing any decay or restorations. We usually don't like to use the root canal teeth, so we want to use those teeth that are not endodontically treated. Remove any restorations, decay, or granulation tissue that are on the teeth. We'll grind and sort that material. Then we'll cleanse those granules, and then we'll rinse and dry and use it as an autogenous type of graft. So in this particular case, we actually use the patient's teeth as a dentin graft. So the first thing we did is, as we're extracting this, my one assistant is removing any granulation tissue, any decay. If there's any tartar on the teeth, we want to remove that, or any periapical cystic remnants that may be at the apical portion of these teeth. So here you can see, as my assistant has started cleaning these teeth, what it looks like. We place it in the dentin grinder. This little machine is very effective, and within only a few seconds will grind this material down. We have several micron particles from 300 all the way to 1200 micron particles to use as a graft. In fact, when a tooth is ground down and used as a dentin graft, it creates about double its weight or size in graft material. So one tooth is great for about 2 grafted sites, which is really nice. So once the material has been grafted and sorted, then we'll dispense it into a sterile cleansing dish for defatting, dissolving of any organic debris, removal of any toxins or bacteria. And the solvent comes with this, with the grinder and the unit dose compules of grinding surfaces, or tops, I should say, containers. And so really it's sodium hydroxide and 30% alcohol. And so the particulate dentin is immersed in this for about 10 minutes. And what this does, essentially, it removes any of that debris from there, and it kills any of the bacteria. In fact, there's been several studies that show that when they do a bacteriological test, there's no growth at this point. All that bacteria has been killed, essentially. Well, once it's been in that solution of sodium hydroxide for about 10 minutes, we'll go ahead and rinse it twice with a phosphate buffered saline solution to remove any of that sodium hydroxide off of the graft. And then using a sterile gauze that's lint-free, we'll go ahead and remove any excess moisture out of the graft material. So here we can see we have a bacteria-free particulate autogenous dentin graft. And so here, this doesn't really cost the patient anything, really. And each one of those unit dose containers is only about $50, and the unit is a very cost-effective unit, which I'm sure Kurt will talk about later. Here we've seen in the different studies that have been out for several years that we do see actually very good bone growth into these areas of these grafts. So what we found essentially is that the enamel works like cortical bones, so it doesn't resorb and change over as quickly as the dentin. The dentin acts as more of like a cancellous bone. So the enamel works as the scaffold, while the dentin is actually turning over and turning into the patient's bone. And so as you can see, there's several papers on that. And so this is something that I highly recommend, especially when you're doing multiple extractions. What are some of the advantages? Well, we see fast bone healing. We also see that you're not going to get rejection or inflammation or fast resorption because of the material. I mean, this is an autogenous graft. We see immediate stabilization, very little recession because the enamel particulate doesn't resorb as quick. It acts like cortical bone, so we don't see that turning over as quickly, and so that holds the ridge very nicely and prevents the recession. We also see a very good tissue response. Obviously, we don't see a huge cost when you're looking at grafting a whole site or a whole arch. That's much more than just one little site. So this is what the Dentin graft looks like in the clinical photos in this particular case. And so then we'll go ahead and remove any excess blood by just blotting this with sterile gauze. And then we've achieved primary closure, so we don't need a membrane in this particular case because we had leveled the ridge down. Now our goal is to go ahead and remove the lower bridge. A very essential tool or instrument in this removal of crown or bridge restorations is the WAM key from GoldenDent. What you do is you just make a little trough and you sort of estimate where the height of the preparation is. And since these are various sizes of an elliptical shape, you put them in this horizontal slot and then you turn it and rotate. And as you rotate, that elliptical shape lifts the crown off the tooth. And so in this case, you can see we actually removed the bridge without using trauma. Again, we're going to go ahead and use some of these teeth for grafting once they're cleaned up. Some of the post-extraction steps, just to illustrate to our listeners, is to curette them out very well. If there's any stubborn granulation tissue, we're going to go ahead and use our degranulation burrs. Once all that remnant is removed, we'll irrigate with sterile saline. We'll squeeze or condense the socket in case there was any expansion when we remove the teeth. We'll rinse the area again and place the graft. If a membrane is needed, we'll place a membrane. In this particular case, we did not need it. We'll suture it, and then we'll have the patient bite on gauze until we get the immediate dentures in. Some factors that may influence healing, which are important to talk about, is if there were large areas of infection. As we talked about, we want to curette the area out. Size of the wound, the blood supply to the area. If you're not irrigating and you're leaving foreign bodies in that area or remnants of restorations, we want to readapt the flap very nicely, and obviously the general health of the patient. For postoperative hemorrhaging, we recommend the pressure pack. We don't want them to bend over or function. You can use tea bags if necessary to control bleeding. We also tell them, in addition to no strenuous exercise or lifting, we want you to take it easy and absolutely no smoking. Well, if the areas that you've extracted teeth, you're not going to be placing grafting, I do at least recommend placing the BioViva. The BioViva is a cellulose-based bacteriostatic, hemostatic, resorbable gauze. So these are very inexpensive. I use these routinely for those patients who don't want to have any type of grafting placed in the sockets, or especially like wisdom teeth where we're not going to graft. This controls the bleeding very quickly. So this is also another product distributed by GoldenDent. So we've extracted the lower teeth, we've leveled the bone, we've grafted, we try in the denture, we see that everything is fit, so everything is now sutured, and so our goal is to go ahead and use a soft reline. Mucoprint is a soft reline from Kettenbach. Tokiyama has a very nice one, which I'll show in the next case as well. They both work very, very well. So here we have the post extraction and grafting Panorex. This is immediately after the extraction once the patient is brought out of the IV sedation, and you can see the Dentin graft actually has a very nice radiopaque look to it. So you can see that we've grafted this area very well, and not only the upper, but also the lower arches. For antibiotic coverage in these large cases, I will have the patient start 3 days prior to the surgical appointment with amoxicillin 875. So they're starting 3 days before and then 7 days after the procedure. So they're actually on the antibiotic for 10 days in these larger procedures. If they're allergic to amoxicillin, then the next antibiotic of choice is erythromycin. If they're allergic to the first two, then we'll utilize clindamycin. Analgesics, what we like for pain is Motrin 800 or 400. If a narcotic is necessary, then we'll go with either Tylenol 3, Norco 325, or we'll combine the two and have them take some Motrin and then one of the Tylenols with the narcotics in it for pain. What I found is a lot of these patients, if you're reflecting the flap ideally and you're taking the teeth out without a lot of trauma, then really they only need pain medication for a couple days. Another drug that I like to use is dexamethasone. I'll start the patient with 4 milligrams before the surgery. So before we put them to sleep, we'll give them 4 milligrams. I highly recommend this if you're doing a root canal. I have yet to have a patient complain of tenderness to a tooth that's been root canaled. So dexamethasone, or Decadron as it's known, is a steroid. So it removes any type of inflammation. So it works very, very well. Getting that bottle, that whole bottle, is about $10 for 100. So it's something that's very inexpensive for the dental provider. If we compare pre and post Panorexes, these are showing you that we removed 23 teeth and grafted those sites. This lady is now ready for implants if she wants to pursue that. Well, her immediate dentures were nice, but we wanted to go ahead and create a better bite. So you can see we have the lower immediate denture, and we're going to reline that, but we had a new wax try-in of the upper. So this is done 9 weeks later. And here we have the final smile. And if you look at the before and after smile of this patient, she's very pleased, and we have a nice natural looking smile in the post-operative view. Let's quickly go over this last case here. Here we have another patient who has severe decay. So we're going to go through and collect all the data, whether it's the health questionnaire, the necessary x-rays, and the clinical findings. We'll acquire our photos not only extraorally but intraorally. We'll also get the models, and we'll get a CBCT or at least a 2D x-ray. So these are the 4 standard photos that will go straight to the monitor from our Bluetooth camera. And clearly you can see this patient has rampant decay. So we're going to identify these areas that need work. Notice she has somewhat of an open bite. This is her biting together, so she has a little bit of a tongue thrust as well. Here we see the incisal edges and the occlusal breakdown in some of these teeth. Looking at the occlusal aspect, we can see how devastated some of these teeth really are. In the lower arch, it doesn't look as bad from the occlusal view, but when you look at the Panorex, you'll see that she has a lot of cervical and interproximal decay, not only in the posterior teeth, but also the anterior, upper, and lower teeth. So we review the various treatment options for this patient. This patient opts to go for a treatment in about $10,000 to $12,000, including the extractions. So the first thing we're going to do is go ahead and take upper and lower impressions. One thing we can do is use the Silginod impressions, or if you're accustomed to using heavy and light body, you can do that as well. Here we're illustrating the Panasil material from Kettenbach. And so here we have the lower impressions. That's the heavy and light. The patient got approved through Lending Club, so we're taking our records as well and illustrating to the laboratory where the midline needs to be. And so here you can see the workup from the laboratory. We're also getting clear duplicates if we need to use that later on if the patient wants to go with fixed restoration. So here we have our immediate dentures ready to go. You can see the internal aspect. They've already reduced the ridge based on where we drew on the maxillary and mandibular diagnostic models. And so we also planned on doing implants in the lower arch. Since this was a younger patient, I said, I'm going to throw in 2 extra implants. So we're going to do a total of 4 implants for you for lower overdenture. So our planning that we did in our CareStream software was converted into 3DDX's software by the team at 3DDX. Here you can see the bone leveling guide that is necessary so that we have adequate bone on either side of the implant. So we're not going to submerge them that much, obviously. We're going to level the bone and then place them ideally. So here you can see the bone leveling guide and then where those 4 implants will be placed using a surgical guide. So this is what we call a stackable guide. So here on the left, you have the foundation guide where you do the bone leveling. Once the bone leveling has been done adequately, we'll place the implant surgical guide right on top of this foundation guide and prep for those areas. So we have everything ready to go. Our nurse anesthetist puts our patient to sleep with IV sedation. So we start using our separators. Here you can see the bayonet separator that's used interproximally to loosen the teeth. You can also use the wedge if you like. Here you can see we're reflecting a full flap. This is the reflector. Notice it's the paddle portion of the Molt 9 with an elevator handle. So this is something we created for GoldenDent that allows us to reflect a flap for a full arch very quickly. So I've already loosened the teeth and I've reflected a flap. Now I go ahead and start taking the teeth out. This is a distal elevator. This helps prevent causing fracture of the buccal plate or removing the tuberosity when you're taking a tooth out. So we've loosened everything up. We reflected a full flap. Now I'll just go ahead and utilize the physics forceps to remove these teeth atraumatically. So you can see we're trying to get the best lever as possible utilizing the physics forceps. It's imperative that we keep the beak parallel to the long axis of the tooth. Notice we got that bicuspid out in one piece. No fractured root tips. Even curved roots, the physics forceps works very ideally. This molar was removed in one piece. And now you can actually really see the extent of this patient's decay at the cervical portion of all these teeth. So yes, in fact, these teeth all needed to be extracted. Now we know we need to do some massive leveling. Before we do that, we're going to go ahead and degranulate those sockets with our degranulation burr. At this point, we'll go ahead and level those tines of bone so that the patient doesn't complain of this later. We'll try in the immediate denture. We see that it fits, so we'll go ahead and use graft material. In this particular case, I wanted to illustrate using a DBM putty if you don't have the Dentin grinder. And the nice thing about this Goldas putty is you can get it strictly as a putty or putty with cortical chips. So here you can see I'm dispensing those within the sockets. And in the areas of the wisdom teeth, you can see I've placed BioViva just to control those areas. There's no need to graft it because we'll never place implants that far in the posterior. Here we've used chromic gut suture to suture that. And now we have the immediate denture. In the lower arch, we're going to go ahead and use the separators as well. We're going to loosen the teeth as much as possible. As we've loosened those, we'll let that hyaluronidase enzyme build up. In that aspect, we'll go ahead and reflect the flap and then come back and utilize our physics forceps. So we'll utilize the physics forceps and sequentially remove each tooth. Again, notice the gross decay at the cervical portion of all her teeth. Now at this point, we'll seat the bone leveling guide once we've degranulated the sockets. Here we see the bone leveling guide as well as the surgical implant guide. Here's the virtual mock-up of it. So we'll place this leveling guide until it's seated. We'll use these osseous shaping burrs to level this bone. Here you can see we've leveled. Then we'll snap on the surgical guide, do our drilling. This is the OCO Biomedical Implant Guided Drill Kit. So here you can see we're going in the sequence of the burrs in the OCO Biomedical Kit. And then these are the Engage dental implants from OCO Biomedical. These are bone level implants with a very good aggressive thread design, as well as a proprietary bullnose auger tip. So we'll place those implants, place the healing caps on those, and then graft the remnant areas. So again, I wanted to illustrate, if you don't have the Dentin grinder, then you can use particulate or a putty graft. We'll suture that into place. Here we have the lower immediate denture. And in the first case you saw we used the mucoprin. In this particular case, we went ahead and used the soft reliner Tough from Tokiyama. So we'll go ahead and do the soft reline of those. This is the immediate panoramic X-ray post-extraction and grafting and implant placement. So if we compare, in one sitting, we went ahead and extracted all the teeth, leveled the bone, and grafted. This is what the ridge looks like 9 weeks later. And so you can see the importance of leveling as well as grafting the areas. So we remove the soft reline, and we'll go ahead and just do a reline impression. This is the Panaso medium body from Kettenbach. Notice we don't have to do any border molding with any extra materials. The medium body works very well. So here we have the upper and lower dentures. At this point, we'll remove the healing caps and place the locators. These are from Zest. The heights of these are about 3 millimeters in height. And so we'll go ahead and do the direct pickup ourselves. What I like to use is the Rebase 2 from Tokiyama. This works really well. You mix powder liquid, load it into the monojet syringe, and here you can see we've picked up the housings for the Zest locators, and then we'll remove the processing inserts and place the 1.5 pounds of retention, which is the blue inserts, into there. And here we have her post-operative X-ray. We do a lot of this type of training at Amplified Dental Training, which is sponsored from GoldenDent. We're at the University of Detroit Mercy. We work on live patients. I'm sure Kurt will be telling us a little bit about that. And then we also do implant training at Ascend Dental Academy, where I'm the chief clinical officer and the main educator. And you can look that up at Ascend Dental Academy. Dr. Levine, I leave it to you.
Well, we're going to turn it over to Kurt here, because I know he's got some great specials to talk about, and talk about the training options that are out there as well. And then we're going to open it up to Q&A. So Kurt,
sounds great.
Pop it over to your screen and go from there.
Okay, perfect. Hello, everybody. My name is Kurt Lawler. I am with GoldenDent, based here in Detroit, Michigan. I know a lot of doctors that are on the webinar this evening join our webinars on a regular basis, but for anybody that is new, we're a Detroit-based company. We're a third-generational dental family, and I always like to show some of these old advertisements we have in our office, which are kind of fun. This is from the Detroit News in 1940 from Dr. Milford Golden, and extractions were $1 back then, and it's kind of fun to look at these old ads, and provides a little bit of history of what we do here at GoldenDent, and we use this this background in dentistry to make and develop good products that are created by dentists that we work with. So I'll mention this quickly before I continue on with some of my slides. I know we appreciate your time for investing your time with us on the webinar this evening. And we always provide a promotional offering on the webinars for anybody that maybe saw something interesting this evening, or if you're a regular customer, it gives you good opportunities to take advantage of some of the discount pricing. But the promotional offer, if anybody wants to take advantage of it, the code is FULL15, so it's just FULL15. And that'll allow you to save 15% on any of our products or our educational programs that we offer through Amplified Dental. So amplifieddental.com is our educational arm, which you'll find more information on our courses. The one that's most similar to what we discussed this evening is probably our AMP3 program. That's where we do pretty much everything that just Dr. Nazarian showed this evening. We go over a good lecture day one, and then day two we actually do everything on live patients. So it's a pretty great program. You don't have to be licensed in Michigan. We do everything at a teaching facility. And as long as you're licensed in the US or Canada, you are welcome to do the surgeries. Physicsforceps.com is our product-based website. That's where you'll see any of the products that were discussed this evening to use that promotional code. I know a lot of doctors that join our webinars on a regular basis probably already have our Physics Forceps, but the standard series set of instruments is our most popular set. This set will work second molar to second molar, upper and lower. It's really going to give you the best leverage, and they're the easiest to use to make sure you like the concept or the technique. With this product, you are never stuck with it if you don't like it. For anybody that's considering the Physics Forceps, they have been around now for about 11 years. There are a lot of users in the market if you have not heard of them before. But you do have 90 days to try the product in your own hands, in your own practice, make sure they're a right fit for you. And if for any reason you don't like the product, you do get a full refund. It's pretty rare. Most doctors are super happy with the instruments. You just have to be open to a little bit of a different concept and technique, and make sure you don't squeeze the handles. It's not really a forcep, it's really a lingual elevator. This next set is the molar series set. This is really an accessory to the set I just showed. This is going to be designed for hard to reach second molars. If you're having issues getting back there, because the standard series instrument I just showed comes perpendicular or straight at the tooth, so sometimes you can't get back to a second molar, and you're definitely not going to get back to a third molar. That's what this set is for. A lot of doctors are just happy with the standard series, but if you do want to also get further back into the mouth and do hard to reach second molars and third molars, this is the set you would want to take a look at. The Wedge, we kind of already went over this this evening. Dr. Nazarian likes this instrument and uses this in advance of the Physics Forceps. It's not an expensive instrument. You can find more information on that on our website. But it's a new instrument for us that we worked with Dr. Nazarian on. The separators, again, these are not expensive instruments. They're like I think they're like $74 or $75 or so with the promotional code. And the bayonet's probably our most popular. And then we also have a straight and a curved instrument. These are also good to use in advance prior to the Physics Forceps, or you can obviously just use these also for the extraction if that's what suits you best. Our allograft, if you're using another allograft, we'd obviously love for you to try the Goldos allograft. That's our allograft brand that we have here. The clinical feedback on the product is actually really great. Now, we've been selling this for quite some time now, and we think our pricing is pretty competitive, but it's not really all about the price. It's a good product, and it provides good clinical results. So we have some great deals on that. If you do the buy 5, get 1 free and provide the discount, I mean, you can get a 0.5 cc for as low as $45, which is a pretty good deal for an allograft. The only thing I'll show here real quick is if you look in the bottom right, you'll see that tip. That's kind of interesting on the putty. It allows you to flow the putty in a couple different methods. You can just take off the black cap and have it shown as it does there in the bottom right, or you can remove the entire white cap and have it come out as kind of like a full flow, so to speak. And so it gives you a little bit more control over the graft material and where you want to place it. It is 100% DBM. There's no fillers. A lot of the products in the market do have fillers in them, and that's not the case with the Goldos putty. I don't. I don't think we talked about the osteogen plugs tonight, because I know we focus more on the full arch type cases. But this is actually a really popular product for us, and we do speak about it a lot in past webinars. This is more for socket preservation, though, if you're doing like maybe 1 or 2 or 3 extractions instead of the full arch cases we showed this evening. This is a really great way to get involved with grafting if you're not grafting now. It's a synthetic bone and a collagen-based carrier. It's pretty much as easy to place as a collagen plug, and it's $42 a bullet with the discount, no membrane, and it's a really great product. I know Dr. Nazarian's been using it now for a number of years with great results, and that's something to take a look at too. If you're not maybe doing the full arches, or if you're just looking for the socket preservation type cases, this is a good product that's you can find more information on the website that you can take a look at. There's 2 sizes, there's a large and a slim. The large is the more popular. BioViva we mentioned. This is definitely something to take a look at if you're currently using gel foam. This is a good alternative. It's inexpensive, and it's also effective. It comes in a packet of 20 pieces, and actually in each little packet there's actually 2 pieces. So I mean, it's almost 40 pieces in the box here. But it's something to take a look at if you currently are using gel foam, or it's a great product for controlling bleeding, or for third molar cases, or cases where you're not grafting. That's something to take a look at. We really didn't talk about membranes too much tonight, because I know the cases they've had primary closure, but the EpiGuide, the one on the left, it's probably our favorite of our customer base. It's a great synthetic membrane. It's large. It's 18 by 30 in size, so a lot of doctors will cut that membrane and actually use it almost to the equivalent of 2 membranes. It's long lasting, almost acts as a non-resorbable membrane, and that's something to take a look at. The CollarGuide's good too. It's the same type of long lasting resorbable membranes, and you can find more information on that on our website too. Smart Dent Grinder, we went over this in pretty good detail, but that's something we do offer if you're interested in creating that autogenous type graft from extracted teeth. This is something you could take a look at also on the site. The reflector, we went over that. It's a good instrument for reflecting the soft tissue easily. It just provides a more comfortable handle and an easier method of doing that. Our graft kit, this is a simple kit. This is not an expensive kit. I think it's around $400 and some for the whole kit with a cassette. So it's a fair priced kit, and it's just nice to have all in one place and all in one kit when you're ready to do your larger grafting cases. If you're looking for more like advanced instrumentation, we obviously do have that also. We have some really interesting like suture scissors and a needle holder and suture cutter combo instruments that you can take a look at on our site. This is the burr kit, which we went in detail. I just have a couple more slides here, and I'll hopefully save some time for Q&A, so hopefully if I'm going over here. But Wegotrix, I just wanted to mention this. This is not obviously a webinar on restorations this evening, but I know we have a lot of regular customers that join our webinars, and if you haven't already heard, we did come out with a sectional matrix system. It's called Wegotrix. The whole kit that you're seeing on the screen is only around $125, so it's extremely inexpensive. And what's unique about the system is the ring. The ring is actually it's a plastic ring, and so it's designed to be disposable. And so you get 35 rings with the initial kit. And what's great about it is you have the guaranteed perfect separation each and every time. You don't have to worry about the metal ring popping off or becoming worn out or discolored when you're sterilizing it. You just toss it with like the wedges in the band. And we've had a lot of really great feedback over the last few months on this product, so it's something to take a look at if you're interested. WegoFill, that goes along with it. This is our new zirconium infused composite material. And Dr. Nazarian has been working with this product for quite some time with really great results. It's something worth taking a look at. We keep everything simple here, so we just have it in 3 shades. And I find that the feedback on this one's been really great too for posterior restorations, which you're going to have minimal shrinkage, really low wear, and zirconia is known for strength, and that's what you really want in the posterior. Lastly, I'll just mention our hands-on courses. Here's just some photos from some past courses we had this last year. We have an extraction, grafting, and an immediate denture program. We have a really great hands-on portion where we do classroom work on models. We do a lecture with Dr. Nazarian. This is the clinic or the teaching facility where our next program's March 22nd, 23rd. And then you'll see we break out. It's a great clinic. You're by no means watching the instructors doing the work. We pair you up with another doctor and you're doing the procedures. You can see it's very comfortable, very large space. We have a ton of operatories and it's a pretty smooth operation. This is Dr. Nazarian giving a live patient demonstration on one of the techniques before breaking out to the individual operatories. And I think that's all I'll mention. And then importantly, we do these specials, which are better than trade show specials at 15% off. We offer them for only 24 hours. So you have until tomorrow evening if you do want to take advantage of the special, which is full 15. And I will turn it back over to Lauren to get into the Q&A session, and I appreciate everybody's time this evening.
Thank you, Kurt. Ara, you got time for some questions?
Absolutely.
Yeah, as I said, we're not going to get to all of them, and I apologize ahead of time. I'm going to try to combine a few of these. So we do have a number of physics forceps users on here. The most common issue concern that I'm seeing, some people are saying that they are noticing some buccal fractures on the maxilla when they're in the canine area. Others are complaining about bruising and hematomas in the vestibule because of the bumper. So how would you best address both those issues?
So if we look at buccal plates breaking, you know, before I had a CBCT, I thought it may be in my technique or something. Once I got the Carestream 8100 within my practice, and I took a CBCT and look at the 3D view of somebody's maxilla or mandible, and when you look at the areas of the canine and the first premolars especially, you see very thin bone. In fact, you may even see fenestrations. So if you rush the procedure utilizing the physics forcep, or you take that rotation and you continue with it, there's an opportunity to break bone. That's number one. Number two, that buccal plate may break no matter what technique you use if there's very thin bone, as we identified if you look at this CBCT. And lastly, this is one reason why we recommend using the separators or possibly the wedge, because sometimes you'll find that these roots are very, very long, the bone is very thin, and if you're going to use any type of forcep or lingual elevator or anything without putting another instrument to it before, there's a possibility that you may break the buccal plate. So in our extraction and grafting course, which is level 2 at the university, that's the first thing that we teach in level 2 is, hey, if you do break the buccal plate, you need to learn how to graft that area, because it's going to be a 3-wall defect using a membrane and some type of graft material, because it will happen. And it doesn't just happen with the physics forcep, it will happen with any type of system if that area of bone is somewhat thin. And we find that very common in the canine areas, because if you look at the cross-sectional view of a canine root, it's asymmetric. It's wider buccolingually than it is mesial distally. So when you're taking that tooth out, there's a higher chance it may break. As far as bruising, I have yet to have anybody bruising. We've seen people, dental providers, cause bruising if they're squeezing too hard or they're not using one of the bumpers, which are the green covers that go over that metal portion that you're rotating around. So usually if somebody's got bruising on the facial aspect where the bumper is, they're usually probably squeezing too hard.
Okay. What about for teeth that have active infections? I know some people would typically suggest, start them on some augmentum for a few days before the procedure and leave them on for a week afterwards. What's your typical antibiotic regimen when you have an active infection going on?
If there's an active infection, my first go-to antibiotic is amoxicillin, 875 BID, And so either I'm choosing 7 days coverage or 10 days coverage. The two examples that we saw tonight, it was a full, mouth. So I went with 10 days. They start 3 days before the procedure, and then they continue for 7 days after the procedure.
Okay. Some people are asking about, I can answer this one, about whether there's going to be a replay of the webinar, and the answer is yes, absolutely. GoldenDent is kind enough to send that out. It usually comes out within the first 24 to 48 hours. The CE forms take a little bit longer, but there's definitely going to be a recording here. How much time does a patient have from the time of graft to implant placement if they're on the fence about getting implants? In other words, how long is a graft good for before it's no longer useful?
Usually I try to convince them that they should have implants within the first year to year and a half. Once a year and a half has passed, then we can't predict how long that ridge is going to remain to the most ideal width or height. So we try to push them to try and do it within a year, year and a half at the most.
Okay. Do you guys use any type of socket shields?
Socket shields as far as using the tooth as a socket shield in that procedure? Is that what the question is?
It just asks about the socket.
Yeah, usually, yeah, that's okay. Usually the socket shield technique is leaving the facial portion of the tooth in the socket and then grafting in there. I'm not a big advocate of it, and the reason for that is, as a general dentist, if I were to leave a portion of the root in there and then later it's examined from, let's say, a specialist, I think they would say this doctor left a root tip in there as compared to he did a socket shield technique. I found as if you preserve the buccal plate and you're grafting at the time of extraction, and depending on what type of graft you're using, if you're using a graft like the Dentin graft where it's not resorbing or changing over very quickly, I personally don't see the need for a socket shield. Do a lot of people utilize it? Yes, but I don't think it's necessary. Just a matter of preference.
Okay. Question here, I guess, about the denture. How often should a practitioner change the O-rings on the implants for the 4-in-1 dentures? Average approximate duration with average patient wear, no parafunctions, any recommendation on implants with retained bar on overdentures?
Wow, that was a long one.
Yeah,
okay.
That's from one of my clients, so she gets to ask a lot of questions.
Yeah, no problem. So we didn't show the O-balls and O-rings. We showed the locators. So I don't know if she means the O-balls or the O-ring, or the O-ball and O-rings, or the zest locators, but I'll talk about both. What I found is if you're using O-rings, you're going to have to replace those a little faster as compared to the zest locators inserts. So depending on parafunction, depending on the patient's bite, depending on how many times they're taking them in and out of their mouth, I would say you need to replace them when the dentures feel like they're loose and they don't have the retention. Now, I would incorporate that into the cost of the dentures. If a patient's presenting every month to my practice to change these, then eventually I'm going to charge them for it. My go-to for overdenture has been more so the two-piece system, which is like a locator type of overdenture. And the reason for that is I can control the height. Sometimes you'll have a deep gingival tissue that a one-piece O-ball will not work, although they do have two-piece O-balls. But I find I have much more control because you can go from 1.5 pounds of retention all the way to 3 or 5 pounds of retention based on that insert, depending on the color, whether it's blue, pink, or clear.
Okay.
And so those I change probably, I'm sorry, those I probably change maybe every year if they come for routine examination and cleaning. And some patients disappear and they come back every couple years to change the inserts only.
Okay. What about resorbable membranes? Do you ever use them to get primary closure? And if not, why not?
Yeah, so I definitely recommend resorbable membranes. My go-to is what Kurt illustrated earlier, which is the EpiGuide. It's a resorbable membrane, but it doesn't resorb that quick. It usually takes about 6 to 8 weeks to resorb, so it's nice. It's synthetic, so you don't have a nasty smell if you don't get primary closure, like you do, let's say, a pericardium. Um, that usually is my go-to membrane. I don't want to have 5 different types of membranes within my practice. The EpiGuide is a very cost-effective membrane that works very, very well from GoldenDent. These two particular cases, we didn't show the membrane because I was able to get primary closure. But if they look at some of the earlier webinars where I talk about extraction and grafting in like 1 or 2 areas that are smaller, or if there's a 3-wall defect, then they can watch those and see how I use the EpiGuide membrane.
Got it. So I'm trying to see what we can get in the next 4 or 5 minutes or so. For bone grafts, are you typically charging on a per socket or per tooth? And can you tell us approximately what you charge? I mean, I know, some people, sometimes a little concerned about talking about your prices, but maybe, what are the typical prices in your area, or however you want to phrase it. But
right, no, that's a great question. So probably what they're asking is, when they saw that I'm doing a full arch on the top and the full arch on the bottom, am I charging the same price for an individual socket? And the answer is no. If I'm doing a full arch, then I'm charging them a certain rate for the bundled amount for all the sockets. And so it'll be a bundled amount, but it'll be a lot less than what I would be charging for the socket.
Makes perfect sense. What if a patient shows up and they can't even do the 4K at the records appointment? Or are you basically not doing the case at that point?
Yeah, I tell them to come to the University of Detroit Mercy, where we do our programs, and they can get free dentistry there at our courses. But
okay.
yeah, I mean, if they can't afford to do it, I do several pro bono cases. But if somebody comes in and says, I want a full mouth of implants, but I can't afford to do it, I can't provide that unless it's a teaching environment.
When you're doing the soft reline at the time of extraction, any concerns about material getting under the sutures or the flaps?
That's a great question. So one of the techniques I use, actually I learned from one of my students at the extraction and grafting courses, and that was to go ahead and take a C-fold towel and cut it in the shape, like a U shape of the ridge, let it get wet just from the saliva, and this way when you do the soft reline impression or soft reline, you don't have material going into the extraction sites.
Okay.
And then you just peel it out of, obviously, the soft reline.
Okay. Any change in your technique or your approach when you know that you're dealing with ankylosed teeth?
So with ankylosed teeth, which is very rare, I will try to use the separators and the wedge. If I see that there's absolutely no movement with that, I will try the physics forceps. Usually what will happen is the tooth is going to break, and so then you'll sort of trench around the tooth and attempt either to use the wedge, separators, or forceps again. And as it just keeps breaking, you're eventually just using the burr all the way to the apex of the tooth. That's probably 1 out of maybe 300 cases, but it does happen.
Right.
And that's the day where you're running over.
Okay. What would you do for those patients that IV sedation just isn't an option? What would be your approach for those types of patients?
If we're still going to be doing full arch?
Yeah.
I would probably only do an arch at a time, see how they go, and then go from there. But I would not try to do a full upper and lower with someone awake. It's just too much. I mean, unless they're, not as many teeth or they're periodontally involved. As you saw, these teeth, they were all severely decayed, but they were not so periodontally involved. So that it's a little more complicated. So in that case, I would just do an arch at a time.
Okay. Just trying to see if we can get a little. This is an interesting question. How did you find a nurse anesthesiologist to come into your office to put your patients to sleep?
It's a friend of the family, so we knew that she was doing it for other dental offices. So I asked, hey, if I can do this every Thursday, would you mind coming in? And she said, no, absolutely not. So we have, within our practice, we have the blood pressure cuff, the EKG, the pulse oximeter, and the CO2 outtake. So you need this type of mechanical equipment to be able to monitor this type of thing. There are some nurse anesthetists, I believe, out there that do provide not only the medications but also the equipment. How you would find them, I don't know.
Yeah.
I'm sure you could Google it.
Okay, and final question, which I think is actually a good way to end this up. You know, people, they go out and they buy the physics forceps and the bone grafting. They go do the education. How do they get the patients in the door? What do you find is an effective way to market for these types of patients that you want to be treating?
Well, one of the things is being able to provide multiple services under one roof and at one time. So one of the things that I found is providing all the services that are within your comfort zone, of course, under one roof really works. And then it's just really word of mouth. That's number one. Number two, you're going to find that the population needing extractions is growing exponentially. And that's not just the young generation like you saw with these two individuals. We see the mature population, our baby boomers, that are increasing in size and number. As patients mature and their teeth are in their mouth for a longer period of time, we're seeing issues of dexterity, we're seeing dryness of the mouth, we're seeing normal wear and tear because of function, you know, of these teeth in their mouth for over 80 years. And so you're going to find that these patients are going to come to your practice to have these teeth extracted. It may not be all their teeth like you saw in these two examples, but you'll see that eventually multiple teeth will have to be extracted. And it also opens up the door for implant therapy. You know, as the director at Ascend Dental Academy, we're finding more and more general dentists, and these general dentists are getting younger and younger in age, wanting to start learning implant therapy. So I think having the ability to extract and graft is definitely a great precursor to being able to provide implant therapy. And if you're the one who extracted and grafted and created a beautiful foundation, then the implant portion is actually even easier.
Okay. Well, we're out of time, so I wanted to thank you so much for your time and expertise. You know, we've done probably at least a dozen of these webinars over the years, and, you know, unlike some of the other presenters out there where it's the same stuff regurgitated and over, every time you're on here, there's new slides, there's new cases, there's new content. I think it's just, I learn something every single time and appreciate your time. Anything you'd like to say before we call it a night?
No, I appreciate you having us. It's always a pleasure and an honor, and I wish everybody a great 2019. Thank you so much, Dr. Levine.
Thank you, Ara, and we look forward to having you back. Actually, I think we're going to be having you back in about a month or so. We're doing a webinar on Class 2 composites, I think. So all of you will be getting invitations for that sometime in the next week or two. As I mentioned at the beginning of this presentation, we could not do this without the generous support and sponsorship of GoldenDent. They've worked with me for years and years, and we always get, you know, hundreds, if not thousands, of people onto the webinars. These webinars are not easy to put together, to market. I appreciate all that they do, especially the fantastic special pricing that they're offering. I would highly encourage you to take care of that. To look into it. Those specials only last for a short period of time. They stand 100% by that money back guarantee. If you don't like it, send it back. You will get a refund. I don't think we've had too many of our clients that have done that because everyone loves the products. But either way, we know for sure that that's available to you. So thank you to them. Thank you to Dr. Nazarian. Thank you to all of you, because we know your time is valuable and we appreciate you being here. And we look forward to seeing everyone on future webinars. So good night, everyone.
Good night. Thank you.